We're going to get together today and talk a little bit about breast cancer. This month, the month of October, is Breast Cancer Awareness Month. And as such, we talk a little bit about breast cancer specifically, as far as what the risk factors are, as far as things that we can do to help reduce those risk factors, as well as specific areas that need some additional attention. The reason why I think this is most important, at least from my perspective, is that there's a history of breast cancer in my family. My first aunt, who was actually a very high achieving lady, she was in the top 10 most influential women in America back in the 1980s, died from breast cancer at the age of 47. And since that time, I've always taken kind of a special interest in the breast cancer process, what things that she might have been able to do to avoid that early demise, what things that I can advise patients about to try and make sure that they're decreasing their risk to the greatest degree. And if they have high risk, make sure they're doing the things that they need to do to be sure they're serially evaluated, that they're keeping an eye on it. Let's go get into it. The first risk factor that most people pay the greatest attention to nowadays is genetic risk factors. Family history, being that if you have a maternal relative, particularly a first-degree maternal relative, a mom or a sister who's been diagnosed with breast cancer, that does increase your risk. There's also a genetic link called the BRCA gene. It's BRCA1 and BRCA2 genes that are not only indicating increased risk for breast cancer, but also increased risk for ovarian cancer. If you have a positive family history, particularly maternal family history of breast cancer or ovarian cancer, you need to ask your healthcare provider to go ahead and get you tested for those genetic predisposing factors. The problem with focusing on the genetics and the family history is that many people use that as the only thing they have to worry about. If they don't have a positive family history, then it's not going to be a problem for me. Here's the bad news. There are many other risk factors. The good news about that is that the majority of the other risk factors are totally reversible, so that if you don't have a family history, or even if you do, there are things that you can do to decrease the risk of those genetic markers and or non-genetic mediated cancers from representing themselves in your body. Number one, obesity. Obese women have a 3 times increased risk of developing breast cancer in their lifetime. So diet, exercise are very important as far as getting your breast cancer risk down, particularly if your body mass index is over 30. Number 2, smoking. Number 3, alcohol use. Number 4, and this is something that most people can't avoid, but the date or the age that you're at when you first start your menstrual period. Women who start their menstrual period early are at higher risk for breast cancer later in life. And as such, they should start monitoring and screening at an earlier age than those who have a menstrual cycle that starts in their early teens or mid-teens. The other thing, also related to your menstrual period, is women who go through menopause later. If you don't go through menopause until your mid to late 50s, then that puts you in a higher risk category. The other thing that is very important and often is misinterpreted by the general public is race. African American women have actually a decreased risk, a lower incidence of breast cancer compared to Caucasian women. However, when African American women are diagnosed with cancer, they have a 40% greater risk of dying from it. And there are multiple factors that seem to contribute to this. Number one, they tend to be diagnosed later in the process. Number two, there's an increased risk of more advanced or more aggressive cancers in African American women than in the non-African American population. We're not exactly sure why that is. Number three, from a demographic standpoint across this nation, African American women seem to enter into the healthcare system a little bit later than those in the more what we call standardized population of this country. And they tend to have different experiences in the healthcare system than those who are not of African American race. And when they're diagnosed, and these are studies from the NIH, national studies, that the type of treatment that they receive is usually less aggressive, even though oftentimes they have more aggressive malignancies that they're diagnosed with. Now, what type is that more aggressive malignancy? What we call a double negative estrogen and progesterone receptor type of cancer. that kind of cancer is very resistant to standard chemotherapeutic agents. And if you don't catch it very early, it's very, very difficult to treat. The other risk factor that I hadn't mentioned just yet is a lack of exercise. A sedentary lifestyle actually increases the risk of cancer in the breast in women and in men. Men have a much lower incidence, but it can still occur in men. So it's noteworthy. So what can we do? Number one, the basics. Good healthy diet, a well-balanced diet, particularly one that's high in antioxidant containing foods, fresh fruits, fresh vegetables. The brighter and the more intense the color of the fruits and vegetables, the higher they tend to be with respect to their antioxidant components. Number two, regular daily exercise. 30 to 45 minutes of aerobic exercise, whether it's low intensity or high intensity, can definitely decrease your risk. Number three, make sure that you're getting your breast self-exams done yearly. You need to be checking your own breasts. They have new guidelines out now in terms of mammogram screening, where women starting at the age of 40 all the way up to age 74 are not required to get mammograms every 2 years. So there's an interval change from what we used to do, where we used to do yearly exams. Now, I want to stress to you that if you're in a high-risk group, if you have a positive history of a genetic marker, if there's a positive history of a first-degree maternal relative who's had a history of breast cancer, you need to express to your physician that you don't fit into that general category, and you need to get your mammogram every year. And you also need to be doing your self-breast exams twice a year rather than once yearly, so that you can catch any kind of an abnormality early and press your physician to be able to look into it sooner rather than later. The other thing that is very important is that since African American women tend to get breast cancer earlier, even though their overall incidence is lower, and they tend to have more aggressive forms, they too are in that higher risk category. The risk of missing a cancer in a woman in that racial and ethnic group is much more serious. I express all the time to my patients that even though the recommendations, and they are just that, recommendations, say every 2 years, I want my female patients to get their mammograms done yearly. And it says only up till age 74. Here's the kicker. Women's risk of breast cancer goes up with age. The highest risk is after age 70, yet they tell us we're not supposed to be doing mammograms after age 74. These are guidelines that are not necessarily what's in the best interest of the patients, but oftentimes they're in the best interest of the insurance companies who are reimbursing for the tests. The other thing that they came to as far as why they've decreased the frequency of breast cancer screenings and mammograms is because they say that there have been too many unnecessary biopsies done based upon abnormal mammogram screenings. It's only an unnecessary biopsy if it's a negative biopsy. If you don't do the biopsy and it turns out that it is a malignancy, then it's a necessary biopsy that was missed. I think it's much better to be safe than sorry. So again, I express to you and I encourage you to talk to your healthcare provider about doing yearly mammograms, even though that's not what the guidelines recommend. The other thing that I want to talk about is there are a certain subgroup of women who have what they call dense breast tissue. You go for a routine mammogram and you get a reading back from your obstetrician, gynecologist, family practice physician from the radiologist saying that this woman has dense breasts. So what does that mean? Every woman's breast is comprised of a combination of fatty tissue and glandular tissue. In some women, they have less fat and they have a normal or increased component of glandular tissue, which on mammogram looks white on the mammogram screening. Well, so too does precancer and cancerous lesions. It shows up as white spots on your mammogram. So it's often very difficult to differentiate between the dense breast tissue and the cancer or the precancer on routine mammographic screenings. So if you've been told that you have dense breasts, if it hasn't been recommended by the radiologist or by your physician, you need to request that you would get additional testing. What is often done is either ultrasound, or in some cases, they do MRI analysis of the breasts, or more commonly now, they do 3D mammograms to get a closer look at the breast tissue. If you know yourself to have dense breast tissue, then you need to be sure that you're getting the appropriate follow-up testing after you get your yearly mammograms. And one other risk factor is postmenopausal hormone replacement therapy. For a long time, we stopped doing hormone replacement therapy in postmenopausal women because there's this reported increased risk of breast cancer when you put them on estrogen therapy. Later studies indicated that actually it decreases your risk of breast cancer when you're on estrogen replacement therapy. However, when you're on combined replacement therapy with both estrogen and progesterone, there is a slightly increased risk. I express to you, most importantly, it's a slightly increased risk. It's so minuscule of an increase that for the most part, with the proper screening, it doesn't present as a problem. But I need to mention it to you anyway. If you've been on combination estrogen and progesterone replacement therapy for more than 5 years, then you need to talk to your healthcare provider about weaning you off of the progesterone and see whether or not your symptoms have improved to the point where you don't need any hormone replacement therapy at all. I hope that if you do have any questions and you feel like they're not getting answered to your satisfaction, you can reach out to me on my YouTube channel. It's Getting Understanding with Dr. Daryl Ellis. You can leave a question there for me, and I'll be glad to get back to you with the appropriate answer. God bless you and stay safe.